Guys outside, could you come in please? For those who would like to attend the Imperial Keratoplasty course. Guys in the back, can we start the slides? Nice.
ومن هذا المنطلق الحمد لله تم تنفيذ يحدث مع المنطلق
وفي الدخلة هي الثانية دي. هبقى لك من الزاوية دي، هبقى لك من الزاوية دي. مش عارف مين اللي بيتفهم. عشان بس يا ابني اديني اي صوره. ماشي يا عم بس لا هو يقطع اللي جوه. ايوه ماشي، ما انا بضحك انت لان انا كنت هنا وهم فصلوا.
Assalamu alaikum wa rahmatullahi wa barakatuh. For the next 1 hour, we are going to have an endothelial keratoplasty course. Hopefully, we will cover all what you need to know about endothelial keratoplasty. For people who maybe have just started doing cornea fellowship, they have started with DMX and D6, and they may think that those procedures are going on for a long period of time. Actually, if we just go to 2001, 2002, when I did my fellowship in Montreal, at that time we were doing penetrating keratoplasty for all corneal pathologies. So all the evolution that you see on those days, it get popularized over the last 30 years. To start with, just we have to remember the first successful procedure of penetrating keratoplasty that was done in 1905 by Dr. Zerm. And from that time, for long decades, penetrating keratoplasty remained the main standard or the gold standard of corneal transplant for all corneal pathologies. The concept of the surgical selective replacement of the corneal endothelium was first published by José Barraquer in 1951. And they have introduced what can be described as endothelial keratoplasty through an anterior flap technique. And there was just limited work on this procedure. The procedure basically was done by creating a flap, lifting up the flap, refining the diseased posterior stroma and endothelium, remove the diseased part, transplanting the bottom of the donor tissue, secure it with sutures, and then putting the flap back again in place and secure it with suture. Despite its selective approach, this procedure was lacking. This procedure did not address problems related to sutures, to the irregular astigmatism, and the delayed visual rehabilitation. So the flap technique was not popularized at that time, and penetrating keratoplasty remained to be done for many decades. In the 1990s, when the procedure of refractive LASIK came in when the microkeratome became popular with the refractive LASIK procedure, so many refractive cornea surgeons, they tried to go back and to see if they can do endothelial keratoplasty by a flap technique. You will find a few publications in the literature that has been done by different ophthalmologists, including Culbertson, Poussin, Azar, Guel, and others. They were trying to create, by the microkeratome, the largest diameter flap that they can achieve, which was around 8.5 millimeters. The maximum thickness they can go for, which was around 130 microns. They lift up the flap, then they can do trephination for the posterior part of the stroma and endothelium. The maximum that they could achieve is between 6 to 7 millimeters. And after that, they will get exposed to the anterior chamber as an open sky procedure. If they have to remove the cataract, they will remove the cataract. If they have to exchange the IOL, they will do that. If they have to do any iris surgery or iris repair, they will do it. And after that, they will put the donor button, they will suture it, and then they will put the flap back in position. Donor tissue was secured in place, as I have said, with sutures, and the flap was put back again in position. But still, this problem. But still, the problem of sacrificing the anterior corneal surface and the topography remain there. So many cases have ended up with, for example, flattening of the cornea for up to maybe more than 10 or 15 diopters. And so that the clinical application of this technique has been abundant. The real start of endothelial keratoplasty was with what we call it the limbal incision technique. And the first concept of a truly limbal-based method of endothelial transplantation was presented by Koc and Associates in 1993 in the ARVO meeting. They performed an animal study with rabbits whereby they have done a limbal scleral incision. They have created a deep lamellar pocket. Then they removed the posterior stroma, and then they sutured in a posterior lamellar corneal button. The grafts were successful in about almost half of the cases, but this work went relatively unnoticed. The importance of this study was that it avoided any cervical corneal incisions or flaps, so there was no vertical cuts, and also it preserved the normal surface topography of the cornea that the previous procedure of the anterior flap technique couldn't achieve. The real start maybe of endothelial keratoplasty was with Gerrit Millis in Netherlands in 1998, where he published his work with cadavers and animal eyes, and he described his development as posterior lamellar keratoplasty. At that time, when he started with a limbal-based incision of 9 millimeters. And with specialized instruments, he created a deep posterior pocket, limbus to limbus, and then he can slip through this pocket a trephine of 7 to 7.5 millimeters, and he trephined out the posterior diseased cornea with the trephine and special scissors. Maybe for people who know Dr. Millis, one of his enemies in endothelial keratoplasty is the use of viscoelastic. So from the time he started doing posterior lamellar keratoplasty, he tried to do the procedure under air. And maybe this was one of the difficulties for others to do the procedure. The donor tissue was prepared by Dr. Millis at that time from cadaver eyes, and he trephined the donor tissue from the endothelial side. Then, by using a special spatula, he was inserting the transplanted graft inside the eye, and then he stabilized the donor tissue by the air bubble, by an air bubble without suturing. So with Dr. Millis also, he started doing endothelial keratoplasty without the use of suture. He was stabilizing the graft only by an air bubble. So the insight which Millis provided was that the transplanted donor tissue did not require sutures to be kept in place. And with this new technique, Millis was able to avoid the two inherent liabilities of penetrating keratoplasty, which are the cervical corneal sutures and the vertical stromal wounds. Dr. Millis, he published his first case of posterior lamellar keratoplasty in 1999. Dr. Mark Terry, maybe for people who read about endothelial keratoplasty, they will find maybe the two people or the two great names that were dealing with endothelial keratoplasty, maybe Millis on one side and Mark Terry on the other side in the United States. So just year after Dr. Millis, Mark Terry has published his work on limbal-based incision technique of keratoplasty, but he named it differently. Instead of posterior lamellar keratoplasty, he named it as deep lamellar endothelial keratoplasty. The changes that Mark Terry has added to the procedure is the use of viscoelastic instead of using air during the procedure, which made the procedure safe and easier for others to follow. Also, to prepare the donor, Dr. Terry, he used the microkeratome to prepare the donor tissue at that time. And he performed the first human limbal incision of DLEC in the United States in March 2000, and subsequently he published his early results for the first two patients. Over the next few years, Dr. Millis and also Mark Terry, they have tried to reduce the incision of their procedure of deep lamellar endothelial keratoplasty from 9 millimeters to 5 millimeters. And by reducing the incision, they have introduced different ways of introducing the donor tissue by forceps and by other ways through which they can introduce the tissue. And at that time, there was a discussion about the rate of endothelial cell loss from using the forceps insertion and the other ways of inserting the tissue. Also, we will find that from that time in other areas of the world, they have also tried to modify the technique of DLIC in different parts of the world. The next move was with what we call it the dysmatorexis. And again, Millis, he was the first one to describe dysmatorexis for the removal of the diseased endothelium in 2004. The advantage of this modification, it was a kind of movement from the BLIC, posterior lamellar keratoplasty, into the DSEC. So the advantage, it provides a smoother interface on the recipient side than with the manual technique of stromal dissection, and it eliminated the recipient deep lamellar dissection, making the procedure easier and safer. The donor tissue could then be placed directly onto the recipient bed. Millis performed this modification of his BLIC surgery on several patients, and he published that in 2003. The procedure of DSEC or DSEC was popularized in the United States, and Dr. Franz Price, he started to use the microkeratome for the preparation of the donor, and he named the procedure at that time by DSEC. And also, Dr. Price was the first one to do an endothelial keratoplasty on a previously failed penetrating keratoplasty. In an attempt to provide a true anatomic accuracy with endothelial keratoplasty, in 2006, Millis has described his first successful clinical application of of his technique in a procedure called DMEC, which stands for Descemet's membrane endothelial keratoplasty. And I remember at that time, people were selectively using either DMEC or DSEC for example, the simple cases, they go for DMEC, and for difficult cases like those with vitrectomized eyes, with the valve, with the peripheral synechia, and they were going towards the DSEC. And over time, maybe DMEC has taken over, and there is right now maybe just, there is no kind of contraindications or absolute contraindication for the procedure of DMEC. Just to conclude, I'm just going to give you a brief history about the endothelial keratoplasty here, the endothelial keratoplasty history in Kuwait. In Kuwait, we performed the first two successful procedures of DSEC in 2011 as a live surgery, part of our annual conference at that time. We invited at that time Dr. Donald Tan from Singapore, where he performed the procedure using his endoglide, and Mark Terry with his insertion forceps. From 2011 till 2014, we haven't done much with endothelial keratoplasty here in Kuwait, till I invited Dr. Martin Derisemer from Austria. He was a former fellow of Dr. Millis, and we have done with him almost 27 cases of DMEC for the period from 2014 till 2017, with the exact typical technique they were using in NEOS or in Netherlands that he learned from Dr. Millis. From 2017, 2018 till now, we had the advantage to have Dr. Rajesh Vogla with us here in Kuwait, and he actively has improved the service of our cornea unit in Al-Bahar. He performed and also trained the great majority of our surgeons here in the unit on how to perform DMECs, DSECs, DALCs, iris repairs, and secondary IOL. And Till now, maybe I just went through the statistics of our endothelial keratoplasty in Al-Bahr. We have done so far maybe 127 cases over the last few years, around 93 cases of DMEX and 34 cases of D6. Thank you. So who's next?
So my presentation will be very short. Majority here is a cornea surgeon, expert cornea surgeon. So I hope I just refresh your memory. So for endothelial keratoplasty patient selection, sometimes it needs a wisdom to do that, but nowadays, as Dr. Ghazi mentioned, we are doing it for even more difficult cases. There is no absolute contraindication for DMEC. However, there is some certain patient that we prefer to do either DSEC or BK. So many corneal surgeons transition from BK to EK because of all the advantages of the EK. And there is different kind of endothelial keratoplasty nowadays. Every day there is a new procedure to improve the patient outcome. So regarding the preoperative planning, it's very important to counsel the patient very well, to assess the patient for their type of anesthesia, whether he can tolerate local anesthesia. Peribulbar block is the main anesthesia we use for endothelial keratoplasty. Sometimes patients need to have certain position, especially patient need to lay flat and also be very cooperative regarding rebubbling, because there is a chance of desmus detachment, and there's a chance of patient being rebubbled on a slit lamp rather than taking the patient back to the OR to rebubble him. So all these things, assessing the patient, cooperation, ability to lie flat, checking his, if he has any back problem, it's mandatory before deciding a surgery like endothelial keratoplasty. Very important thing is taking a very thorough examination through the anterior chamber, looking for if there is any starting from poor visibility. So if the cornea is not visible and you cannot see through the cornea, that makes your endothelial keratoplasty very difficult and very challenging. However, with the modified techniques like pull-through and DSEC, you can even do it even nearly blindly. However, having anterior chamber IOL will make your life difficult for a DMEC procedure, whereas in a DSEC procedure, it will be easier. Other things is the lens status. So we have to assess how is the lens stable. If there is, for example, a loose zonules, or there is a weak lens diaphragm that will not maintain the pressurizing the anterior chamber, this will make our surgery failure rate higher and the rate of detachment higher. So assessing this thing by checking the anterior chamber depth as well as the iris damage, to see is there is a lot of iris tissue loss, is there is any iridotomies, is there is any synechia. All these things play a major part on deciding what kind of endothelial keratoplasty. Also, if there is a tube or previous glaucoma surgery, will make the surgeon life during the surgery, maintaining the pressurized chamber as well as orientation of the graft without damaging cells, make it difficult. Other things you have to decide during the counseling of the patient, where is you're located. If you are located in a well-equipped center, it makes your life easier to do, for example, a DMEC, which is the elegance procedure. Sometimes you have to decide to go more for example, a DSEC, which give you a nearly good visual acuity, as very close to a DMEC when you go for ultra-thin DSEC. So sometimes you have to go wise to decide on the type of the procedure you are planning. And sometimes even a BK, you decide give you a better outcome whenever there is a significant corneal scarring. So assessing how much corneal scarring in the cornea also play a role on the success and the outcome of the patient. There are many questions to think about. So who are the best candidates for endothelial keratoplasty? Of course, everybody likes to see a patient of Fuchs dystrophy. We don't see it here a lot in Kuwait, but it's very common. In Europe, in the US, it's common. So it is one of the best indications for doing DMEC. Also mild bullous keratopathy, where there is a lot of inflammation and posterior synechiae, and the IOL is stable. It's also a good candidate for a DMEC. Patient that should be avoided as early stages of DMEC in cases where there is a poor view of the anterior chamber and there is anterior chamber IOL which causes inflammation. Sometimes you need to remove it without even doing any procedure at the same time. Also a lot of iris damage, tubes, aphakia, which makes sometimes the tissue lose to the posterior segment, as well as maintaining the pressure. Sometimes you need to put a suture to rescue even a DSEC. As we said, stromal scarring, as well as potential vision. So always, these patients is tricky. Sometimes we need to assess their potential. So assessing visual potential is mandatory by looking to the posterior segment. Is there any cause of the reduced vision? So we can see clearly the patient photo down on the right, which shows little bit poor visibility of the anterior segment. However, the patient on the top, where he has a Fuchs dystrophy, which is a straightforward DMEC. So sometimes you need to stage your procedure, and this all planning should be done in the clinic. Taking the patient to OT, it should be, the last thing is the fun time. You know your plan, you know everything what you are planning to do. So whether you want to stage the surgery, especially if there is anterior chamber IOL, which is causing you inflammation and it's unstable. So better to remove it, put a scleral fix or retropupillary artisan, anything that support your anterior segment, and then implant either a DMEC or a DSEC. Sometimes also when the patient is aphakic, sometimes putting a scleral fix previously to pressurize the chamber. Most of the scleral fixation give you a hypotony post-op. This hypotony induces more endothelial detachment and makes your success rate of endothelial keratoplasty lower. So sometimes being patient, I mean that staging the procedure, it's wiser. Uncooperative patient, very important. Whenever you are doing longer surgery, try to avoid doing combined surgery. Sometimes also staging the cataract to reduce the inflammation post-operatively. The good thing is endothelial keratoplasty does not give you a lot of astigmatism, does not give you a lot of refractive changes. So whenever you are planning, also you have to do biometry, and this biometry has to be expected that you target some slightly myopia, so around 0.75 to -1, which is within the normal for these patients to get a good outcome. Avoid doing multifocal. Toric IOL sometimes forgiving, but doing this premium IOL might induce to you some unexpected outcome, which you don't want to see with these patients. So going for monofocal lens is better. So in summary, so every procedure has its learning curve. Better to start with straightforward cases in a better setting. Select the right patient who you counsel very well. And then learn all type of procedure. You never know, any surprises happen during the OT, and maybe sometime you have to do some different kind of maneuver during the OT. So you have to master all kind of procedures and then under-promise the patient and over-deliver. Thank you for listening.
After listening to the history of endothelial keratoplasty and the indication, we come to talking about a step-by-step approach to easy DMEK surgery. DMEK, as you know, stands for definitely most easy keratoplasty. We heard about the history and the evolution of endothelial keratoplasty, and currently, if you see worldwide, DMEK is becoming the preferred technique of endothelial keratoplasty among corneal surgeons. The faster visual recovery, minimal refractive shift, and the reduced risk of rejection makes DMEK the preferred technique over other forms of endothelial keratoplasty. And again, worldwide, if you see, the two main indications are pseudophakic bullous keratopathy or Fuchs dystrophy. The surgical steps basically involves a proper case selection, donor preparation, because in our part of the world, eye banks don't yet give us pre-stripped tissues. Rest of the steps are the wound construction, decimet stripping, performing the inferior PI, which is very important to avoid pupillary block, donor insertion, unfolding, giving tamponade using air or gas, and the post-operative management. Ideal case should have adequate visibility, and your anterior segment should be relatively intact, which means that it shouldn't be a unicameral eye. Your lens iris diaphragm should be intact. This study, when they did a review of all the fellows who had finished fellowship training with Dr. Gerrit Mellis, they found that almost half of them were not doing DMEK, and from the fear of either damaging the donor or putting in an upside donor graft. And donor grafts are quite expensive outside in the Western world, and if your insurance is not paying it, it becomes a very expensive affair. You can get patient-ready DMEK donor from the international eye banks. In our part of the world, we get the whole cornea, the corneoscleral rims, and we have to prepare our own graft. If we look at it, ideally, if you have to prepare your graft, select a tissue between 50 to 70 years of age, ideally cell count 2,400 or more. Do place a F or an S stamp on the stromal side, which will help you with the orientation, and typically trypan blue staining for 1 minute is sufficient, but you can stain it up to 2 minutes. Loss of donor tissue can result in cancellation of surgery. You have to get a second tissue, which is more expensive. So even although the tissue loss rate varies between 2 to 20%, over a period of time, once you cross the learning curves, it's fairly reproducible. And even if you do damage some part of the tissue, you can still use it for surgery. Putting in the S stamp or the F stamp from the stromal window was a nice addition, because prior to that, when we were doing surgery, there were various maneuvers that you had to do to ensure that your graft was in the right orientation. And you do a surgery, and the whole night, half the time, you're wondering whether you did put in a upside-down graft till you see the patient the next day. Other ways, besides the S stamp, you can make these peripheral triangular notches going in a clockwise direction when you see it from the stromal side, or putting asymmetric marks in the periphery. But still, then the F or the S stamp are the more commonly used one. This is something we have designed. It should be, because of COVID, it got delayed, but it should be in production end of this year or next year. So here we have an illuminated punch, which we designed. So basically like doing a capsulorhexis with the retroillumination. So here, when you prepare your donor, because of the retroillumination, you are able to see the decimet's margin much more clearly. And if you do encounter any kind of breaks, horseshoe tears, you can identify them much more early and avoid damaging the tissue completely. Wound construction you can do through a clear corneal or a scleral incision, make 2 paracentesis, and if you are doing a surgical PI, you can do a vertical inferior paracentesis. Decimet stripping can be done under cohesive viscoelastic, which maintains the chamber and you don't lose the chamber. It can be done under air, which gives you maximum contrast, but then air leaks out and you have to repeatedly keep filling the anterior chamber with air. You can connect a AC maintainer and have your assistant keep injecting air as the air leaks out. And usually the stripping is 1 millimeter larger than the size of the donor. They did comparative studies and found that if your area of stripping is a little larger, the rate of dislocation is lower and you need to do with reduced rebubbling rate. Inferior PI, if your peripheral cornea is clear, a preoperative YAC PI can be done a week earlier, or intraoperatively you can do that using a vitrector. Be careful in phakic eyes. In phakic eyes, I don't like using a vitrector because I don't want to damage the zonules, and So in those eyes, I make an inferior paracentesis and do a surgical PI. For donor insertion, you can have dedicated glass injectors, or you can create one from any of the IOL cartridges as well. So all of them do work. It's basically, commonly we use a fluid-based injector where flushing the donor into the eye. But sometimes if your anterior chamber is not very deep, you can get a fill of the AC, and then as the chamber gets pressurized, you can have, if you have a leaky wound, your donor can shoot out of the main incision, or sometimes if you have made a leaky side port, it can try to go towards the side port as well. So this is something that you really need to watch out for. The various configurations that a donor can achieve, this is a nice site by Peter Wellman called patientready.org, and he shows all the various configurations. We will come back to the unfolding later. The open end of the scroll should be facing towards the surgeon and not towards the iris. We published our paper on trying to create a double scroll configuration by agitating the fluid. If you see that, you move the tissue between the narrow column and the wide column, and as you push the tissue from the narrow to the wider part, as the tissue opens up, when it scrolls, it can go into a double scroll configuration. Our success rate was about 85%. The second thing, what we did was we tried to create a unidirectional flow where the AC maintainer is on to keep the chamber form. Once the tip of your cartridge goes into the eye, you can stop the flow and disconnect the AC maintainer from the IV tubing. That allows the fluid to leak out. And you can see that your donor goes in a very controlled manner, and the orientation of the scroll is not lost. These are the various configurations that you can achieve using a no-touch technique. Using 2 cannulas, you can tap on the surface, and keeping the chamber slightly shallow, not very deep, you can get the scroll to unfold. And if it's in the reverse configuration, you can always flip it over by creating fluid currents within the anterior chamber. You can do that if you have a tight scroll. We'll come back. I think I have another presentation on unfolding, but the other technique is an endo-in technique, which is pretty much like a DSEC technique where you pull through the DMEC donor into the eye, but that again requires a different learning curve and a different skill set compared to the one that you're using traditionally by flushing the donor into the eye. You can look at the orientation if you have access to an intraoperative OCT. You can look at, in real time, see the configuration. And this is quite useful when you're dealing with very edematous or hazy cornea. You can use the intraop OCT, but it's an expensive device. But in future, I think as the cost goes down, more and more people will be using that. Do a complete air fill, air versus 20% sulfur hexafluoride. Sulfur hexafluoride gives a longer tamponade. And comparative studies have shown that the sulfur hexafluoride does not cause increased endothelial cell loss. But what it does is, especially if you have used intraop myotics to constrict the pupil, the incidence of posterior synechiae is high when you use long duration tamponade. So postoperatively, remember to keep your pupil mobile by giving some dilating drops. And also, if your patient has a hydrophilic lens, maybe avoid using long-term tamponade because the opacification of the IOL can occur. Detachment, yes, there are variable rates. At least in my hands, it's somewhere less than 10%, 8 to 12%. And this can happen. If it happens, it usually happens in the first week, and when the air is kind of going off on the 3rd or 4th day. So usually when you're doing your surgery, see the patient on the first day, but at least try to see them a week later when the air or gas is reduced considerably. It can occur either because of low pressure, leaking wounds, sometimes the patient may accidentally rub the eye, or it can also occur because of inherent characteristic of the donor tissue. And looking at the way it curls, if it is curling towards the anterior chamber, then it's most likely that you have an upside down graft. But if it's curling towards the stroma, that means your donor is in the right orientation. So anterior segment OCT is quite useful. Look at the edge of your donor graft and you can figure out whether you placed the graft in the right setup or not. If your visual axis is involved and the edema and the separation is more than 30% of the surface area, and I think the better to go ahead and rebubble. And surprisingly, I've found that once you rebubble, I've very seldom seen a repeat detachment of the donor. Most of the cases, once you rebubble, they stick very well. And it's a very simple technique which we will, so in this case where there was only a slight peripheral separation, we did not rebubble, we just waited and it spontaneously cleared. Because of the speed of recovery, sometimes you can even do the second eye over a short period of time. We don't have to wait for 6 or 12 months to do the fellow eye. And there have been instances when I've used the same pair of corneas for the two eyes. I did one eye and then a week later I've done the other eye. So if you look at the results, yes, outcomes are definitely better than DSEK in terms of visual outcome. The refractive change is less than 0.5 diopters. The endothelial rejection rates are less than 2 to 4%. And looking at the learning curve, yes, between DSEK and DMEC, the learning curve is not very different. In terms of an experienced DSEK surgeon doing DMEC can still achieve much better visual outcomes. The only thing is that in the initial learning curve, the endothelial cell loss may be a little higher. It's important that in your learning curve, do some wet lab training, both for donor preparation and inserting the donor into the artificial chamber where we use the latex glove as a diaphragm. And you can practice the same steps of the DMEC surgery before you do it on the patient. So basically, in conclusion, the faster visual recovery and better quality of vision and better refractive outcome with the reduced rejection rate makes DMEC the ideal procedure. But it's ideal till the future when we have endothelial cell culture-based technique, and then all this will sound very rudimentary. But till then, I think we have to manage with DMEC, and a stepwise learning approach can definitely make the procedure much more easier to perform. Thank you. I think we have the next speaker who will talk about the DMEC donor preparation, Dr. Wadha.
I'm Mudhal Sadoun, cornea and refractive surgery specialist in Al-Bahar Eye Center. I'm going to be talking about DMEC donor tissue preparation, the no-touch technique. It's a critical step in DMEC surgery preparation is the preparation of the donor Descemet's membrane while minimizing the trauma to the endothelial cells, especially that donor tissue is prone to tears and endothelial cell loss. There are many proposed techniques: manual dissection, the scuba technique, pneumatic dissection, liquid bubble dissection, with a special modification to the fluid-assisted Descemet membrane separation FAS, which Dr. Fogler will explain thoroughly. Scuba peeling technique is the most popular. Talking about scuba peeling technique, in this technique, we use 1 forceps to peel the Descemet's membrane, double trephines. One is a large trephine, about 9.5 to 10 millimeter trephine, and then we peel, then again reposition the graft, and depending on the chosen size, most probably 8 millimeter trephine. Young donors' cornea are very difficult to strip, so if we're starting, or for DMEC unusual, it's better to use a tissue that is above 50 years old. Soak the DMEC graft in undiluted trypan blue for 30 to 40 seconds. If the staining wasn't sufficient, we can always repeat the staining. This is a video where we can see the scuba technique. Here we're using a 10 millimeter partial thickness sponge to create a partial thickness like trephination to be able to isolate the edge of the Descemet's membrane. Here with a stain with trypan blue to find the edges exactly where the trephine the edge. Here we're draining it again. submerge in BSS. Here we're using a microfinger to identify the edges of the separated Decimase membrane. When you see that the edge is bouncing back, this means it's involving stroma. So this is not the right plane, so go to another place and find another plane. You will know that you're in the right plane where it doesn't bounce back. I think now in the video where you see here it's bouncing back. Once it stops bouncing, like here it stops bouncing, then you know this is the right plane for the DM. And then we do a 180 degrees separation of the Decimase membrane to be able to peel it in like a taco configuration. Here the peeling under BSS to decrease the surface tension on the edemic tissue. Again draining. After that we create a window in this trauma about 2 to 3 millimeters to be able to stain the tissue for the orientation. So here we return the Decimase with no touch technique, only with the flushing with BSS and draining from the other side. After that, flipping the cornea and like drying the window. It's very important to dry the window so that when we do the mark, the ink doesn't submerge. Drying and making sure that it's well dry. Here with the Sinski, it's the easiest mark is doing an F mark, and it's easy also during the surgery to identify. Again, flipping the cornea back. And then here now we do the 8 millimeter partial thickness sponge to separate the outer donut that we have created from the previous separation of the donor. Again, staining it with trypan blue. Now we can identify the donut, the edges that between the large and the small trephines. It can be easily removed now. And after that, it's the only time that we actually touch the donor. This is the only time that we are touching the donor tissue. Other times it was always in the peripheral 10 millimeter edge, which is actually not used in the surgery. Here we place it again, and then after that we can stain the tissue. This is the liquid bubble dissection technique, where with a sharp instrument, sharp knife, MVR, behind the iris base, we create an opening, we open, and then after that, using like a dissector to identify the plane. After that, inserting a cannula inside a very blunt cannula within the plane that was identified. And now the surgeon is trying to increase the pressure so that the fluid doesn't come out from the opposite direction. Here the bubble is created with trypan blue. It has two advantages. We are not touching the Decimase at all. And the other advantage is that even staining is done at the stromal side instead of the endothelial side. So the endothelium is not even stained with the trypan blue. Now draining the fluid from inside, and it's now totally separated. We can here go directly with the size that we want to use the graft. Taking this tissue and putting it in tissue media, you can see it's totally separated. With a blunt dissector, we can also make sure that the other side is dissected, and you can see now it's dissected and it's ready for use. What I've talked about is the separation of the Decimase membrane, but with increased demand on corneal tissue, split cornea tissue raised. So it was first described in 2010 by Lee et al. And the Hindel in 2011. They described the split cornea transplantation approach by combining both DALK and DMAC procedures in two recipients on the same day. This reduces the tissue shortage and at the cost of the corneal transplantation. There was another proposal or another proposal where one donor cornea was used for 3 recipients. It was described by Vajapayee in 2007, where the cornea was used for anterior lamellar therapeutic keratoplasty, DSEC, and cadaveric limbal stem cell transplantation. In the picture, you can see that the anterior part of the cornea, which is the 90% of the cornea, untouched, can be used for DALK and the DMEC procedure. To do such and use the cornea for both the anterior part for the DALK and the posterior part for the DMEC, we need to mark our cornea or DMEC tissue without creating actually a window in the stroma. So this is another way of Dr. Fogla's video where how to stain the DM without actually creating the window in the stroma. Here the marcation is done under air bubble where here he's injecting the air bubble between the two tackle, between the DM, and then now drying. And then after that, just marking with the same, with the Sinski, marking the F mark. Here the F mark, and here we definitely can make use of both parts of the cornea, the DM itself and the stroma, since the stroma is also untouched. Here, clear mark, and then we can go back to reposition it and use our 8mm Treefine for the final graft size. Another way to mark the DM is to mark it over a contact lens. Here, same peeling technique, scuba peeling technique, but without creating a window. We can put a contact lens and after that mark over the contact lens. It's very important to treefine the contact lens before putting the DM, because it helps to create a surface tension so that when we flip it, the graft stays, and then we can mark it. It's dried from the sides, and then as if it is the cornea button, we can dry and then remove the window of the contact lens, dry and mark. Again, we can use one cornea for the DMEC and the other and the DALK at the same time. Another proposal was there where hemi-DMEC half moon may mimic visual outcomes of standard full moon DMEC. If so, then hemi-DMEC may have the potential to double the availability of the donor tissues for DMEC. Larger series with outcomes and allograft rejection are needed to decide whether it's safe or with the similar clinical outcomes to go for a hemi-DMEC. These are some of the studies that show for a 1 year provide that similar visual outcome for a full moon or a half hemi-DMEC. This is also 1 year hemi-DMEC endothelial keratoplasty. It is the same, shows, but further studies are needed. There is another concept in transplanting endothelial cells. Here we can see that there is the DMEC CD, which is centrally treefined, and the DMEC PD, where it is peripherally treefined. We can see that around the periphery, the cell density, the endothelial cell density, are higher than the central part of the cornea by approximately 9 to 22%. Based on studies. This was mentioned in literature more than 35 years back. Also, this is another study I found in literature that comparing DMEC CD, which is centrally treefined, and DMEC PD, which is peripherally treefined, and the cornea, and the study states a peripheral endothelial cell density and Descemet's membrane endothelial keratoplasty, that the corneal endothelial cells density increases from the center to the periphery, but in both peeled and unpeeled corneas. Eccentric trephination increases the number of transplanted endothelial cells. However, and they have similar clinical outcomes over on the 6 months and the 1 year studied. However, more study on that part needs to be explored for the future to know whether we can go for a intentional eccentric trephination. For now, we're coming into an era that there are pre-strapped, pre-stained, pre-stamped, and preloaded tissues. Many studies are ongoing and are released and published. Most of the studies are saying that it's some of the studies are saying that pre-stripped tissue have less endothelial cell loss compared to preloaded. However, this may mislead us as the pre-stripped tissue needs further manipulation from the surgeon, so this may compensate or finally they might be the same. But all the studies are promising, and maybe we will, in the future, will depend on preloaded tissues. Thank you.
Very nice presentation, and only word of caution is when you get a tissue from the eye bank, and before you start preparing your tissue, just put a few drops of trypan blue. The trypan blue will stain the dead endothelial cells, not the viable ones. That can give you an idea of, because sometimes the eye bank technicians, when they are preparing, I have seen donors where the peripheral 10-20% of DM is off, because when they are removing that iris from the trabecular meshwork, they can tear off the peripheral DM as well. At least that happens to me. I've reported to the eye bank. And also the stippling, you will see that the stippling on the stain is more in the periphery. So always try to access an area where there is no stain, and you know that you can finally harvest your graft from that side. Now, this technique of the liquid bubble, or I thought maybe a fluid-assisted decimal separation seems to be a better term. So the difference is that when I tried using that technique, I had a success rate of about 60%. So this is something that I learned from another eye bank technician, Eric Abdulalev from Lions Site Eye Bank. So here, instead of using a cannula, you use a 27-gauge needle, and you insert it just outside the trabecular meshwork from the sclera, and as you traverse the trabecular meshwork into the clear cornea, try to stay in the periphery and try to keep the bevel facing up towards you and very close to the decimus membrane. And if you have any peripheral staining of the DM there with the trypan blue, that makes it easier because you can visualize it quite better. As you give injection of fluid, you will find that initially there may be a little bit of, the stroma becoming edematous, or at times you even get a little bit of the air in your syringe. You can see some stromal emphysematous kind of thing, and then you get this peripheral bubble. I don't try to go entirely with the initial injection, and initially when I was using diluted trypan blue, but you can use clear BSS because you can see the peripheral type 2 bubble much more clearly. And in the second attempt, you can pass your needle, again starting from the sclera, and go into that initial bubble that you created, and then you can keep injecting till you enlarge the bubble. And once you have done that, just break it in the periphery using a sharp knife. The trypan blue dye leaks out. You can just hold the graft vertically, and by gravity, most of the dye will be out of the pocket. After this, you can use the same principle as what you have been using, our double trephination. I use a 9.5 millimeter trephine and just do a trephination, so you get the peripheral part which is already free. You can do an asymmetric punch as well, so that you don't punch all the way around. Then you can fold it like a taco. And then it's important that you can either use a stromal window to do the marking. I think it's coming very dark there. I don't know whether your visibility is something like what we are seeing here. So the S stamp is similar to what we have been doing with the air bubble. So when you're using an air bubble in that interface, use a 1 ml syringe and take less than 0.1 cc of air and a 30-gauge cannula, so that even when you try to put that small air bubble, you don't put a very large air bubble. Otherwise, what will happen is the air will leak out, and also you have to keep your graft little vertical, elevated, don't keep it flat. Because if it is kept flat, the moment the air comes out, the taco fold will again fall back. So once you have done that, the stamping, then you can again reposition the DM donor, and then you can punch out the desired size that you want. So for me, my surgeries, I usually do this step, and before I punch, that's the time I take the patient in the OR, so that I'm sure that my donor preparation is perfect. You can do it intraoperatively as well. As you see that the overall manipulation of the donor is much less than what you do, because even here, the whole edge is completely free. You can just go with your Sinski or your manipulator and just get the entire graft to be free. This is good. After we started that, when we started doing this technique, we did 10 cadaver eyes where we practiced, and we found that it was fairly reproducible. If you inject too fast, you can get a type 1 bubble instead of type 2. If you advance your needle too deep, then also you get a type 1. If you put the needle forward, then also you get a type 1. A 1 ml syringe is good, but it's too long. So to hold it in your hand and to go with your needle into the peripheral sclera, it's a little difficult. A 2 cc syringe is reasonably okay. Take about 1 cc of BSS in it. 5 cc creates too much pressure. So the more you inject force, the more tendency for a type 1 bubble to form. So in the periphery, if you keep your needle, so when you see that stromal edema or the emphysema happening, you just keep injecting gradually. Don't inject with too much of force. If you inject with force, you will see a bubble that's, instead of the periphery, the bubble will start in the center. When it starts in the center, you know that you've got a, but even if you get that, you can select a different location and you can still inject in the periphery. As you will see here, that we place the needle. You can do multiple attempts. So even when the learning curve with a single donor, you can practice creating the type 2 bubble in different quadrants, so you don't have to go through the entire thing. So at least it gives you where you're placing your needle together. You can see here we are injecting fluid, but we are getting the bubble circumferentially in the periphery. And then you can go back, and now you attach the needle to your syringe, which has the trypan blue. Get into that type 2 bubble that you have created, and then you can inject the dye. So that way you can be sure that you are in the right plane, and you can see that the bubble goes all the way. But mind it, if you have those abnormal donor corneas with abnormal adhesions, just like you have problems when you're stripping, even here, the liquid bubble or the FATS technique will have the bubble will encounter the same resistance, and it can tear the decimates at this point where your resistance is. There have been instances when during donor preparation, the bubble has started, but then it has broken to the periphery. So you have not got a complete bubble going all the way. So then you have to fall back on doing the scuba technique, but at least you have some part of the edge which is already free. And if you have got a complete large bubble and you put a 9.5 mm Trifine and punch completely, then the donor may become free all around. So be careful when you're creating a taco, at least if you want to mark. So that's why when you punch with a 9.5 or a 10, just try to hold the Trifine a little asymmetric so that it cuts on one side and the other side it can retain an uncut. This I find it very useful, so without making the stromal window, you can quickly create your marking. And you can still transfer this onto a contact lens and do the similar mark without making even a window in the contact lens. And then the remaining tissue you can use the same day for a DALC, or you can put it in a fresh bottle of cortisol and use it the next day for a DALC. So I think that's what it is about using this technique. I had tried it out when it was first described, but then I was using the same principle of making a pocket and then going with a cannula. But what was happening was most of the fluid was leaking out, and you were not able to achieve it consistently, and scuba was working in most of the cases, so that's when we started doing it. Now this one we do, it takes about 3-4 minutes, and it's pretty fast, and I feel the overall manipulation is much less, and the learning curve is also quite short. I think we are done with this. Thank you.
think it's the other. Is it this talk or is it the other one? I don't mind which way round we do them, but I think it's the other one first, isn't it? Okay, so I was asked to talk about the evidence-based difference. So what is in the evidence in terms of comparisons between DMEC and DSEC. We all know that EK is really the mainstay for endothelial disease now over full-thickness keratoplasty. And from 10 years ago, where there was only 300 DMECs being done a year in the US, that's more like 15,000 now. But you can still see that there's at least, well, slightly more DSECs done per year. So there must be some reasons for that. So we'll look at some of the issues surrounding the evidence between these two types of procedure. Some of the pitfalls with the studies is kind of using quite heterogeneous groups when you're comparing DMEC with DSEC in terms of the eyes that are included, the technique that's included in terms of, in particular, what type of DSEC technique, the thickness of the graft, how the outcomes are reported, complications. I think the main thing to also remember is that there's still a role for DSEC, and we should never feel pressured into doing a DMEC for the sake of it. So the importance, a DMEC, the perfect eye for a DMEC is an eye that you have a good view, you have a normal lens iris diaphragm, and you have potential for good vision. And there are some exceptions to that, but essentially this is a perfect eye for an endothelial, for a DMEC. And actually in the UK we see a lot of Fuchs, so a lot of our workload is this kind of newly presenting Fuchs patient, often even combined cases with the lens, and this is perfect for DMEC. Whereas this kind of eye, an only eye, multiple glaucoma operations, failed previous corneal graft, multiple retinal operations, you can see that you can still get a very good outcome with a DSEC. And why subject this kind of patient to the risks associated with complication of a DMEC and the difficulties associated with DMEC when actually with a DSEC they will still have a very good outcome. And then this kind of eye, which is aphakic, with bilateral trauma with lots of operations in both sides, glaucoma operations, previous penetrating keratoplasties, retinal surgery, you can still achieve very good vision with a DSEC. And if patients don't have a good visual potential, you know, this patient, even with a clear cornea, you can see their vision ended up at count fingers. This isn't the ideal kind of eye in an aphakic eye with a pars plana tube to be trying DMEC. That said, it's not to say that some of the kind of more challenging eyes don't deserve a DMEC. This is an eye that's had a failed penetrating keratoplasty and then has had rejected DSEC. So, you know, this is still an eye that, although it probably would be easier with a DSEC, if they've had more than one episode of rejection, it's certainly a good indication to use DMEC, which we know for sure the incidence of rejection after DMEC is significantly lower than after DSEC, probably under 1%. So if we look at the outcomes first, well, we know clinically, even before we get to any papers, we know everyone's got a patient like this in their clinic that's had a DMEC in one eye and a DSEC in the other eye, and they both perform very well. And the first review from AAO actually was a bit unfair because it resoundingly did say DMEC has better visual outcomes than DSEC. But amazingly, even in this review, the group of DSEC patients even included manually dissected DSEK, DSEC, which is a bit of an unfair comparison. And before the randomized controls came up, all these studies, all of which were retrospective, you can see how inconsistent the comparisons are. The DSECs are either not reported how thick the graft is, or it's over 100 microns. Some of the series are triple procedures, some of them aren't. Follow-up varies, and how they report vision varies. And lots of this, you know, was published at a time where DSEC, since then it's evolved a lot. A very thin, ultra-thin DSEC is very different to some of the earlier manually prepared DSEC tissue. So these are the two main randomized controlled studies. There is also a third. There's the Dutch study and the study in the US. And you can see even in these studies, there is some heterogeneity in terms of, in the DETECT study, some of the cases were combined, whereas in the Rudy Newt study in Holland, none of them were combined cases. And the visual acuity in the Dutch study looked to be equivalent to DMEC, but better in the US study. But then really most of the other outcomes it wasn't powered to report on. For sure, the consistent theme is that the complications, in particular the rate of rebubbling, was significantly higher, at least 6 times higher in both groups, in both papers, of DMEC versus DSEC. In terms of the higher order aberrations, again, neither study was powered to report on this, but essentially they didn't find any significant difference in terms of the higher order aberrations between DMEC and ultra-thin DSEC. And in terms of the power changes in the cornea, surprisingly, actually, they found the hyperopic shift was equivalent between the two, and the spherical equivalent was the same between the two, although, again, none of these outcomes were actually appropriately powered to say with any surety. So even the conclusion in ophthalmology from the DETECT study, they say that the study does suggest that DMEC has better outcomes, but then you can see that actually they've had to admit that this can reflect in type 1 error in terms of whether the paper was actually powered correctly to detect any visual difference. And the subgroup analysis in the DETECT study also found that the ultra-thin DSECs, if the graft thickness was less than 70, it was probably about the same outcome as DMEC. So, I mean, this is probably a slightly defensive of DSEC talk, as you can tell, but I think we all see patients in clinic and see on a day-to-day basis that the visual recovery is much faster with DMEC. Often the uncorrected visual acuity is much better with DMEC, or almost always is, but there's certainly still a role for DSEC, and there's no compelling evidence otherwise.
Yeah. Well, the RCT by Winston Chamberlain, which was published in the Ophthalmology Journal comparing ultra-thin DSEC and DMEC, did show that at 6 months or 1 year, maybe the visual acuity is comparable, and they also tried to assess the high order aberrations, and they found that the posterior cornea high order aberrations were higher even when the visual acuity was good. With ultra-thin DSEC compared to DMEC. But in real-world scenario, I think both give equal results. So if you see that at 1 year down the lane, I think there is no difference between ultra-thin DSEC and DMEC. So for me, I try to preserve as much as endothelial cells as possible. So if I have a complex scenario where I may be able to do a DMEC, I would still go ahead and do a DSEC because surgical time will be less, and you can still give, more viable cells for that patient. Now, a few tips and tricks on unfolding the DM scroll. One is that always look at, when you have a single scroll, look at the open, the V pattern, and that should be facing towards the surgeon. So you always try to rotate the tip of the cartridge to ensure that this is facing towards the surgeon when you're inserting, so that you're able to get the open and the scroll facing upwards. We spoke about this So if you have a leaky wound, and you can see that here I have a lot of positive upthrust because my speculum is too tight, which I did not notice. I'm trying to release fluid from the side port, but my graft is refusing to stay inside the eye. So it's important to size your wounds better. And this part, we just imagine that it did not happen. A lot of times when you have, you just nudge the tissue in. There have been descriptions where people have gone with a microforceps into the AC, and they have, instead of pushing in, they have tried to pull the tissue in. But it happens, and sometimes you have had tissues which have disappeared from the anterior chamber, and you have found that they are lying outside on the conjunctiva. And recently, I had a surgeon whom I described my technique of putting an AC maintainer and doing it. So he went back, he replicated it, and he presented at our meeting, where he put the AC maintainer, not a 25 gauge, he put the regular 20 gauge, but he put it at 6 o'clock. And then he's gone with the injector across the iris, very close to the tip, and he's injecting the graft, and the graft disappeared. Where is the graft? The graft is in the tubing, because it has gone through the AC maintainer. In the video, you could not see that he has injected and he's searching everywhere, nowhere is there. Then he played the video in slow motion, and you can see the graft is in the tubing, you know. So positioning, understanding the surgical principle, how you do it, that's also very important. We spoke about all this. So the common technique is like the first video that you see, where we put in the graft into the anterior chamber. I always like to secure my wound, because when you're tapping, you don't want your graft to pop out of the eye. And be gentle in your tapping. Don't keep the chamber flat, because if it is completely flat, you won't have space. I like using 2 cannulas, because with one cannula you can stabilize the part of the graft which is already open. And in the other cannula you can use, either you can tap outside the graft, so when you press and release, as the fluid moves out, it takes the scroll like that. Or you can tap proximal to that, where you're trying to create fluid waves that will push. And at the same time, if you do have a paracentesis in that quadrant, sometimes just releasing fluid from the paracentesis, as the fluid goes out, your scroll, which is like that, it will flip open. Don't try to do it with the main wound. Main wound, you don't have control. Sometimes you press on the main wound, and you find your whole graft will come toward the main wound and get stuck in the main wound. And even putting the air bubble, always watch the cannula. The cannula should turn blue. If you're passing your cannula and if you're over the graft, you'll actually push the graft either down onto the iris. And I always feel that I recommend not to take a 3 cc or a 5 cc and inject air. I always take a tubercle in 1 ml syringe, keep only 0.1 cc of air, so that when you inject air, you will inject only a very small air bubble, and it cannot displace the graft. Sometimes you're, like Professor Dua was telling, that your syringe plunger is stuck, it doesn't move freely, and then you push and you get a sudden burst of air into the anterior chamber, and your well-opened graft, it can get pushed to the angle on the other side, and then you have to do the entire process again of unfolding the donor. If you have a graft that's kind of folded into a taco, instead of tapping continuously, give a short burst of fluid below to the iris, which kind of takes the taco like this and flips it, it kind of rotates it. So always try to get the scroll facing upwards, and once it is opened up, then you can try and use the same steps what you are doing it. I'm using centering, but you see that my one cannula is keeping the chamber flat. It's not allowing the graft to come back to that quadrant. So it's important when you want to move the graft, you're always in a shallow chamber. By depressing one side, keeping it flat, not giving space, you can get the graft to move to the other side. Here you can see peripheral tapping, and I'm keeping one edge fixed with one of the cannulas, and I'm doing peripheral tapping, and I can get my graft to open up. Also, if you feel that your graft is getting stuck in the angle, instead of persisting and trying to move forward, sometimes giving it a rotational movement, you will find that the graft will disengage from the angle much better, rather than just trying to push it forward like that. Here you will see, this is called as the Dirisamer maneuver, where instead of tapping outside, you press down on one edge of the graft, and using the other one, you tap proximal to the fold and do like a carpet unrolling, like playing drums. You know, you keep the chamber slightly shallow, and you can get the graft to open up. And remember that once it is opened up, unlike a DSEC graft which can move when you sweep or you make golf stroke and it moves, a DMEC graft, if you just tap in the periphery, the ripples of fluid waves that happen will carry the graft forward. But if you try to tap on the graft like that, what happens is the moment you finish and the fluid wave goes back, sometimes you'll find that the graft, instead of moving forward, will come back towards the angle. And if you keep it too long, the DMEC graft is so thin that it sticks to the stroma. So sometimes you have to tap on the surface to disengage it from the stroma before you can get it to move. Otherwise, you will find that there have been instances where during surgery, despite whatever I do, it doesn't move. I've gone with a microforceps, I've caught one edge of the graft, and I've just pulled it to center it. Very deep chamber or vitrectomized eye, where the lens iris diaphragm does not rise up and you fail to achieve a shallow chamber, you can put an air bubble within the scroll and use the air bubble as an instrument to get your graft to open up. And in fact, when Melissa described, this was a standard technique of putting an air bubble on top of the DMEC scroll and using it to flatten it on the iris, and once it is opened up completely, then you aspirate it and then put an air bubble below. So that's a very useful technique when you have vitrectomized eyes or eyes high myopes or where the chamber is very deep. If you have put in your graft the reverse way, and this is quite useful since you have the F or the S stamp. Otherwise, previously, we used to look at the edge, how it is scrolling, or we would then pass a cannula and try to come to the periphery looking at the Motsuri sign. So here you can see that you're not directing the fluid towards the scroll. Your direction of the fluid short burst is towards the iris. So basically, you push a jet of fluid towards the iris and the scroll. So before you do that, you have to make sure that your scroll is free. So deepen the chamber, tap the periphery, get the scroll, the DM scroll to get into a scroll configuration. And it should be, the paracentesis, the scroll should be perpendicular to the paracentesis. Then you can get it to move. And remember that sometimes if you inject too forcibly also, the current continues. And there have been instances when it has rolled twice. That means it was upside down. I injected a burst of fluid. I was very happy when it was rolling, but then you can't control the current. So what happens is by the time you do that, the graft has again gone back, and suddenly you find that, oh, I did flip it back. Again, you see the F or the S in the reverse orientation. If you have a very tight scroll, you can either put an air bubble within the scroll, or you can use one of these cannulas, which this is something that I designed, which close at the tip. It has two side openings, so you can orient the tight scroll along the paracentesis, and then you pass your cannula into the scroll and give a short burst of fluid, and that short burst of fluid converts that tight scroll into open scroll. But at the same time, before you bring your cannula out, just try to depress the wound and release the aqueous, because if your chamber remains deep, that will again go into a tight scroll. And once it has opened up, then the rest of the manipulation is pretty similar. For preparing the pull-through, you can see that we have to manually trifold the donor, so it will not spontaneously. Spontaneously is always endothelium is on the outside. So here you are manually trifolding it, stain it, and then you can use a IOL cartridge. You load it. That's a Sensor AR40E cartridge. We use a microforceps and bring that folded part towards the tip. That's a ICL plunger, which I use, or you can even use a Merocel, break the edge, and then use it to close the cartridge from behind. And then keeping the AC maintainer, you can pull the endo-in donor. And once it is inside, you can put a small air bubble within the scroll and then manipulate that to open up the graft. So this was a patient with ACIOL where we didn't want to remove the ACIOL, and we did the DMEC endo-in technique. And you can see that's a patient by post-op day 3, by post-op day 7, patient was already seeing 20/30. This is again another, this was a series when we got into that, after Busin published his endo-in technique, we said, okay, let's do that. But the position of the AC maintainer is very important when you're doing a pull-through technique. This is not a right position. You will see that in a short while. Because of the way the fluid current is going into the anterior chamber, you can see that the orientation of the scroll is not maintained. So don't let go of the graft. You can always come back, remove the AC maintainer, tap on the surface, because often what happens is the graft gets flipped over and you're still holding on to it. So if you deepen the chamber, you see that And once it's opened up, you can then put an air bubble below and you can complete the surgery. I like using this when I'm doing cases like ICE syndrome where there are peripheral synechia and I don't have enough room to flip a graft if it's in the upside position and there are more iris abnormalities, the donor will get stuck and it will not flip over. So there, by using a pull-through, you can ensure that your graft orientation is in the same orientation. So that's the same patient. You can see again by day 5, the patient is already 20/30. So this we already spoke about. So basically this is what we do. We keep the AC maintainer flow on, get the injector tip into the eye. So otherwise you tend to keep a shallow chamber and put your tip inside the eye so that when you're injecting fluid, you have enough space for the fluid. In that scenario, what has happened is in few cases, I have engaged the iris when I'm trying to get my tip of the cartridge inside, and I have induced bleeding from the iris. So here what happens is when your AC maintainer is on, you can safely get your cartridge into the eye without engaging the iris. Once it's inside, you can rotate it to the desired direction, and then you can stop the AC maintainer. Then ask your nurse, disconnect. Once she disconnects, then you can start injecting the graft into the eye. And to verify that unidirectional flow, this is during cataract surgery. I just connected the AC maintainer and I was injecting trypan blue dye into the eye, and you can see how it's flowing out from the AC maintainer just to prove that you have that unidirectional flow when you're disconnected from the AC maintainer. So you can see that it goes in slowly and the orientation, the open end of the scroll facing upwards is maintained. There is no tendency for the graft to rush out of the wound. And you can then suture your wound, and you will see that this is in real. I've not edited this video. This is in real time. You can see that you tap on the surface, you already see the double scroll. And once you have the double scroll, you know that's the best configuration for unfolding. You just press on the surface. I'm releasing some fluid from the side port, so that end of the scroll is already opened up. And then you just center the graft by tapping on the opposite side. Again, release a little bit of fluid, and now this part is open. You can always, so you always, when you let go, you have to let go slowly. If you are very fast, the graft will tend to move. Now again, pin this side, tap on the other side, and you can get the graft to open up. So in this, we found that the overall endothelial cell loss at 6 months was lower. It was about 16.7, which could be attributed to the lower, the shorter unfolding time, and the overall manipulation was also less compared to what we were doing earlier. Because the earlier technique, we were just simply going to get the tissue into the eye. And then we would suture, then we would look at what configuration it is, and then spend a lot of time injecting fluid and keep on. So this is again another one just to show you with the AC maintainer attached. Again, you look at the open end of the scroll is facing up. This point of time, the chamber is formed. Now you can see those wrinkles, so the chamber is getting shallower. You can just put in the graft and come out. You see that the graft is kind of following you, like, it's a very gentle method of insertion. You don't need too much of pressure to unfold that. And you can see that by tapping, already one edge has opened up. You can center the graft, pin, and as you tap, the remaining part is opened up. So it's fairly a simple process when you use this technique. These are all unedited videos, what I'm showing here. So you can see that it makes life much more easier and much more predictable in majority of cases. Can you play that? I think, just go back and play. Yeah, we spoke about the marking earlier. This was the donor mark over the ink, which Dr. Wada already showed you. This was described by Megan Stryko by putting the air bubble, so that makes life much more easier. Besides the intraop OCT, you can also use the handheld slit beam with which you can see the orientation of the scroll. What happens is if your scroll is double scroll, then you will see two lines, or if the scroll is facing upward. But if you see only one central line, that means your scroll is upside down. So that's again another way of figuring out whether you got the scroll in the right orientation or not. So that's in short about donor unfolding. I think we are already running above time. So the next presentation, you have, yes? You're talking about the chair.
Okay, so I'm going to talk for a few minutes about EK and CHED. Broadly speaking, keratoplasty in children is quite different to adults. Primarily, there's a positive vitreous pressure you experience in kids. The sclera is less rigid. You get more of an inflammatory response, intra-op and post-op, and the kids themselves have increased risk of trauma. And the cornea itself has quite a different consistency to adults. So the risks of PK in kids even more than adults because of the subsequence of trauma, but there's also increased risk of open sky surgery relative to lamellar keratoplasty, increased risk of immune rejection. Whoops. And then, of course, amblyopia is a concern for sutures being in for a year, and then an increased risk of glaucoma relative to lamellar surgery. So we're going to talk about endothelial keratoplasty, specifically in CHED, but these are the general kind of conditions that endothelial keratoplasty has been described in children. So the advantages are it's not open sky surgery, so the risk of infection, inflammation is much lower, the visual recovery is much faster, and failure is much lower than with a PK. Faster visual recovery is particularly useful in children because of the risk of amblyopia. So what are the challenges for kids endothelial keratoplasty? Well, firstly, the AC visualization can be difficult. They are all still, well, almost always still phakic, so lens trauma needs to be avoided, unlike in adults where it's often patients have already either had lens surgery or combining with lens surgery. And then Descemet's membrane itself is more difficult to remove often in children. And so DSEC was described several years ago now, and there was 15 eyes that did quite well. 4 of them had detachment, but 3 of those were rebubbled successfully, and only 1 out-and-out failure. To put it in context, this is a patient that I saw a couple of years ago in Southend in the UK, a 12-year-old girl. This is her right eye. It's the worst of the 2 eyes. She had a CHED. She had it in the family. And this is to emphasize the point we talked about Descemet's being thicker. You can see this white, kind of really quite obvious Descemet's membrane, which you wouldn't see necessarily in Fuchs. And you can see, so usually I do decimetrectomy under air, but because of the positive vitreous pressure, I'd already tried under air here and then put an AC maintainer in. And then after scoring Descemet's, in this case actually, it was relatively easy to remove Descemet's having scored it. And you can just see the appearance that Descemet's is kind of a bit thicker than normal. And it just comes off in one kind of tough sheet. So ideally, actually, it's good to try and avoid going over the pupillary margin, although you can see I've gone through pupillary margin there. And now when you remove it, it's all, you can see I put it on the cornea. It's just quite different to the Descemet's that I'm used to seeing in adults with Fuchs. It's quite thick. And then really after that, the rest of the surgery is much like an adult DSEC. So the graft is loaded onto the glide. And so you usually use about 8.25 millimeter graft in this context. And then we prepare it to pull into the AC. And keep the AC maintainer on, partly because you want to avoid touching the lens, but also may well encounter some positive vitreous pressure. And the rest of the surgery is kind of fairly uneventful. So this was her first eye, And the question mark really after this was what to do with the second eye, because actually, so this was actually the first eye I did with CHED, and because my understanding, having seen a few eyes done with CHED, is Decimase was quite difficult to detach. I thought, considering the first eye was really actually a lot more straightforward than I was expecting, what to do with the second eye. So the outcomes of DMEC have been reported by someone that's done many more than me, and with very good outcomes. So for the second eye, I thought I'd try DMEC. I think it's quite nice having done, when you know you've already done one eye, presumably patient's Decimase membrane usually probably behaves in similar ways between the two eyes. And if you know the first one's gone quite well and been relatively easy to detach, maybe it's not a bad idea to try DSEC in the first eye and DMEC in the second eye. So I just put air in there just to make sure my decimeter axis was complete, and then this is just a PI with a retractor. And then here's the Decimase membrane. It wasn't matched for age. It's an adult tissue. I think it'd be rather tight if it was a child DMEC tissue. It's a goiter system. And actually, I hadn't watched this video for about a year, and my fellow gave it to me a few days ago, and I think it was actually a bit lucky, really, because you'll see that the DMEC was kind of almost thrown in, and then it almost came back out again, but luckily it didn't. And then it was actually relatively easy to position, and then just needed a few nudges of BSS to get it back in. It was just slightly trapped in the wound. And then just put some air underneath. So I use the mark that you saw on a slide earlier with Dr. Fogler. I use the triangular mark. I just find it's really repeatable. When we get tissue from the eye bank, I often find that F, if they've put it on, especially if it's flying from Italy to the UK, the F is quite worn out, and I can't really see the F anymore, so I can't see if it's upside down or not. So I always mark the periphery. So this is how she did. She had a DSEC in the right eye, and you can see there's also a little fold of her own thick Decimase hanging out in the corner there. But otherwise, she did very well. She had quite a hyperopic shift in the first eye that I did as the cornea thinned, and she's ended up at +5 in the right eye. But she has good vision. She probably has a degree of amblyopia in the right eye, and the left eye is doing well. It's been about a year or so. And the cell count is, oops, that's actually cut it off. Sorry, the picture's moved. It's about 1,200 in the right and about 1,900 in the left eye, which had the DMEC. One other thing that I didn't do, but I think I'll do next time, is try and move the paracenteses to avoid the pupillary margin, because the patient's a phakic. So, in summary, I think a reasonable approach, and I'd probably do the same again next time I have a child with CHED, is that I will do DSEC in the first eye. You tend to operate on the worst eye. It's likely to be the amblyopic one anyway, or the more amblyopic of the two, so the visual potential is likely to be worse. And you get a chance to see what their Decimase behaves like and what the risk of subsequent detachment is. And then you have a chance to decide whether you're going to do DMEC or not in the second eye. So in summary, really broadly speaking, with EK compared to PK, it's a safe procedure. It's a bit trickier than in an adult, but in terms of comparing EK broadly with PK, it's the same as in other diseases and in other age groups. It's just superior visual recovery and lower risks generally.
I can see where you're coming from, but in adults,
Okay, so in that kind of case then, would you say, once you've done DSEK in the first eye, do a DSEK in the second eye? Or are you saying do the first eye, you do the better eye first as a DMEK?
How confident?
It was my first patient with the CHED, so...
You see, we published 3 papers
yeah.
last year.
Yeah.
And we analyzed our outcomes and we saw that if you do a pre-op anterior segment OCT, that OCT, the decimals, the become hyper-reflected, doesn't look thick, you don't need to remove the decimals. So there, if you try to remove the decimals, you will not be able to get it off, and you will make the inner surface more irregular. So we left it, and we did a non-decimal stripping DMEK, and it worked very well. And
So
we
in that...
found that below the age of 8 years, usually you don't need to strip the decimals. And above the age of 8 years, the decimals is usually thicker in shape, and a thicker decimal is quite easy to remove. And in eating under cornea, removing under air is better because your corneas are still clearer. The ones that we have operated, the corneas have been much more hazy and much more thicker, up to 1,000 microns. But if you keep like a hybrid that you put a little bit of viscoelastic and then put air bubble in the center, so the peripheral visco prevents the air from leaking out, and at the same time you can get the DM to
Okay. Thanks.
But given a choice, I would still do a DMEK in CHED.
Yeah, in both, yeah, from the start. Yeah.
But I think the fundamental concept where usually to one eye the second eye will do that, but there's an adult or child. That question is what we need. Each has their own experience. I don't have pediatric experience, but adult, they're always better than being a child.
Oh yeah, for sure.
More concerned in terms about the
12.
Because we know that when you do a DSEK in an eye, the posterior curvature becomes more myopic. So the hyperopic shift may be more inside. And usually, like you mentioned, sometimes you get bizarre astigmatism because the central edema resolves faster than the periphery. And you get like great shifts in refraction which may take time to get.
Do you think it is the posterior curvature that is the main driver for hyperopic shift? Because
the differential resolution of edema is again like what you
Yeah.
see sometimes in DMEK as well. And the other thing that we have noted, which has been seen in previous publications on EK, but people have not commented on it, is that you see folds in the cornea, in the anterior
Yeah, I
cornea,
saw your
not in
paper
the
on that,
posterior
yeah.
cornea. And the only explanation that I found was that the concentration of dermatan sulfate and keratin sulfate is different between anterior and posterior. And one has a greater ability to retain fluid, that's the anterior part. The posterior part has lower ability. So when you put in a DMEK graph, the posterior cornea, edema resolves faster. But the anterior cornea still, so the mismatch of curvature between the anterior and posterior would be the reason why the anterior cornea is getting prone in folds, because the posterior cornea has got flat. Because of faster resolution.
I think the posterior cornea always swells more than the other.
That's because maybe it's not.
But it is because, the point to think of is you've got a feeling, what happens to the stone, whatever the thickness in a DSEK, does that also get covered with endothelium on the sides? And until it's doing that, it is so. And that's why there is the weighted change is called.
That happens in DMEK as well. Because DMEK, you have a lot of edema. That's been published from LS group as well. They showed that you get a pseudo hyperopic shift because of faster resolution of central edema makes the posterior curvature more myopic. And as the peripheral cornea edema resolves, this hyperopic shift resolves.
I mean, that's outside the DMEK graph.
Yeah, Can I have my videos, please? Yeah, this is the last part. We know that you need to do rebubbling. Mark Terry's group had described this rebubbling on slit lamp, and this is what we do in our clinical practice. Can you play the video? Oh, okay, let me try, yeah. Yeah, this is a patient with a failed PKP where we did a DMEK, and you can see that at 1 week post-op, when there is no air left in the anterior chamber, there is separation of the DM donor, which can be seen. So definitely the whole cornea looks edematous, so, and the patient is unhappy because the visual recovery is not there. We need to go back and rebubble. And if you see on the anterior segment OCT also, at that point of time when this video was prepared, we did not have the, we still were using the older OptoView, which gave us only 6 mm. So there you can see clearly you can see that if you look at the peripheral edge, the edge is curling towards the cornea, so we know that it's in the right orientation. But in general, the DM is not well opposed, so you need a 5cc syringe, which can be, you can connect a filter to it and you can take sterile air. You need a extension tubing, 30-gauge cannula, and maybe a slit knife or a MVR knife. Clean the eye, you put some anesthetic drop, an antibiotic drop, put in the speculum, and make a peripheral paracentesis at about 5 o'clock. And then on slit lamp, you can go in with your cannula, and you can, because you're not holding the syringe in your hand where you're holding the cannula. The syringe is in your left hand. So this hand is only holding the cannula. So you go into the eye and then give a push with the left hand, which is much more easier to perform rather than holding the syringe in your hand and going to the patient's eye, which is also very intimidating for the patient as well. And you can see that day 1 post rebubbling, the DM is attached and the cornea is already looking clearer. And by day 3, the bubble was clearing the pupil, so patient was able to see better and was happier. So this is day 3 post-rebubbling. You can do it, but the problem is always taking the patient back to the OR is a bit challenging because it needs to be scheduled and the expense is also higher. You can do it in your LASIK room with the patient lying down, but nothing like sitting on a slit lamp where you can see your position of cannula and you ensure that it's always behind the decimates and you're not actually detaching the decimates when you do the rebubbling. And that's the post-rebubbling. You can see the OCT in the donor is well attached. This was another patient who had history of several episodes of uveitis, had a total cataract. This was done recently, so I went ahead. I did a phaco, IOL, and DMEC for this patient. Sorry. Can you click on the video? Yeah, if it's, yeah, so it's playing. So he came back on day 5, and you can see that the entire cornea is severely edematous, and when we do that anterior segment OCT, you can see that the entire DM was separated. This was a 76-year-old donor with not too much of tendency to curl, but the cell counts were good. Again, we did the same technique, putting in, making a paracentesis at about 5 o'clock, and then go back with the cannula, inject the air. Sometimes you have to wait. The opening has to be a little larger to allow aqueous to flow out. If you just use a needle and go in and the aqueous doesn't come out, then it's very painful for the patient as well. So you can do that in 2 steps if you want a complete air fill, that you put in first like a 70% fill, wait for the aqueous to seep out, and then you can go back in and put the remaining air bubble and you can get a nice complete fill. Then you can ask your patient to lie down and you can see that the patient had a good outcome. And here we found that putting in a speculum was also painful for the patient, and because of the Bell's phenomena, because you're making the paracentesis inferiorly, it doesn't, so if your patient is not comfortable with the speculum, don't put a speculum on the eye. You can still do that without placing a speculum on the eye. So a slit lamp rebubbling is reasonably easier to perform. We use a millipore filter that we connect and then we aspirate, so that kind of filters out the air. Or if you want, you can even ask your nurse in the OR to prepare the syringes and send it to you, and you can still do them in your outpatient department. And being on slit lamp, you can always ensure. So we do that for even post-cataract surgery DM detachment. We always find that on slit lamp, you can make a fine slit and actually you can see your cannula where it is. Whereas when you do it with the patient lying down, sometimes you're not very sure, and you're always afraid that if you put an air bubble in between the decimates and the stroma, you will actually detach the whole DM back down. So that's in short just about slit lamp. So now we would love to hear your comments.
I'm going to make one comment. Since the last time we should have an entire section of endothelial keratoplasty without mentioning it.
Yes.
Because, believe me, people who do PDEC
No, there is a very recent paper from Namrata Sharma which got published in Cornea. They did a RCT comparing PDEC with DMEC. So that's proof. That's not like one-sided. They have done an actual study where I think they have enrolled 15 eyes who have done PDEC, and they have done 15 eyes which have done DSEC. This one of the girls did a thesis for post-graduation, and that's got published just in Konya, maybe just 3 days back. It's come online.
So what was the conclusion?
Conclusion was that the outcomes are similar. The endothelial cell loss was slightly lower with PDEC. The detachment rates were also lower with DMEC, although the N is equal to only 15, but they found that the detachment rates were lower and the endothelial cell counts were slightly better with the PDEC, but not statistically different between the two. I have not read the paper. I have asked Dr. Namrata Sharma to give me the paper, but in terms of size, yes, when I have done PDEC, I found if you don't want any peripheral stroma, 7.5 is what you can easily get.
Yeah. But also, if you remember, Amar Agarwal, he says he's never done DMEC. He does only PDEC, and he's done more PDECs than anybody else, I think, although I'm biased because this PDEC is my baby. It's the first time I suggested PDEC as a procedure in the first paper which we discovered the layer on. But because he only uses eyes below the age of 50, which is the starting age for DMEC, you can see in the long term, if you get the technique right and you go past your learning curve, your endothelial cell densities will survive for longer, particularly if you go down to the age of 2 and 3 as donors. Now that's rare, but if one concentrates an IBAC, concentrate on that, you will find that much more in the 20 and younger donor age group will come to the fore for endothelial keratoplasty. But before we reach that, like you said, the endothelial cells will come and everything will be out of the window. But it's important to bear in mind that it is an option, and it is a viable option. And for beginners, it is much easier because the unfolding and the scrolling is less and all the rest. So we published a lot about folding of DMEC and PDEC tissues and DSEC tissues and all the rest, and that's what. So that was one point. The second point is that I've seen in many of these videos that the paracentesis or your MVR incision is made at a point where it bleeds. Now, you get away with it because the flow of the blood is away as the aqueous is coming out, but you get even a tiny bit of blood in the eye with the DMEC, forget it. You get a fibrin strand, single fibrin strand in the eye with the DMEC, it is impossible to open the DMEC unless you tease it, much more handling. Sometimes you have to take it out to peel off the fibrin strands and then try and put it back in because you don't have another tissue. And I had a case, very unfortunate, I've had 3 cases where complete failure happened because of fibrin strand, and 2 of them were due to blood. One of them was where the patient just suddenly had a fibrin reaction during the operation. And it turns out, looking back at his notes, he had old history of herpetic keratouveitis. And now we were doing a DMEC, and his iris, suddenly there was a gush of pigment release, and I wondered why that was. But then so much fibrin came that the DMEC had gone completely away. So blood in the eye, and that's why I always worry about doing a PI during surgery. If it bleeds, you have to wait. Patience is on your side. That blood will stop. The iris bleeding will stop. You clean up all the fibrin, then insert your graft. Otherwise, you're in trouble. So that was another thing that we hadn't discussed, but I thought I mentioned.
We didn't talk about complications of DMEC in this session.
Right. But these are intraoperative problems.
Absolutely.
Yeah.
Absolutely. So if you get bleeding during PI and all, just fill the check, close your wound, fill the chamber with air, maybe have a coffee, come back and do the surgery. Don't keep washing out the blood again and again, because the more you wash, the more the blood will keep coming and it unnecessarily will stress you out. So always waiting for 5 minutes, then you can easily go and remove. But never try to tease that little bit of blood that is still sticking to the PI, because if you go there and again try to clean it, it'll start bleeding again. And even if you go with your donor, sometimes, perfection is the enemy of good, whatever maybe that came out wrong. But if your graft is not perfectly centered, And if you can still complete it, and if there is bleeding, complete it at that point of time, because you just try to make the graft center, you will lose whatever you have had. Because we have faced this problem, if it's in the right orientation and it covers majority of the pupillary area, just put an air bubble and that will still, cornea is very forgiving that way. But if you try to spend time, it's going to become messier and messier as you go ahead.
There's one other trick that I noticed, that if your AC is deep and you've got 101, I've actually learned a few tips already. If you impale your tissue in the angle and tap it, you know your DMEC scroll, if your AC is deep and you inject your DMEC scroll, put it into the opposite angle. It's narrowed, so it's fixed over there. And then when you tap, the top bit opens, and then you can nudge it to center it. Because once it starts to open, you can get it all to open. Otherwise, in the deep antechamber, it is just bouncing around, but you can fix it by putting the roll into the angle, because it's much narrower than it fixes. So I've found that was helpful for me. It happened accidentally the first time, and then I started doing it deliberately, if it's like...
The people from Moria sent me a video. I don't recall the name of the surgeon, but he makes peripheral nicks in the DM, which gives the DMEC, instead of going into a complete scroll, it makes like a Napoleon hat. It makes a triangular. So because it has a break in one edge, so once you put it into the air and tap to the surface and you try, instead of going into a double scroll like that, it goes into a triangular. So that way, opening up, I believe, is easier. But I wouldn't make any radial cuts in my donor.
Because I've had it fold. It was an inadvertent tear at one edge, and it folded. And then it's very difficult to unfold it once you've got air. And you don't want to refloat it just to open that. So you can, either way, you could win or lose here. But if the paper gets published, there is a new technique that will come, the easiest way to reduce your tightness of scroll at any age.
Yeah, people have looked at temperature, people have looked at duration of trypan blue staining. I'm sure he'll come out with some, like he spoke about in his talk about using enzymes or something which we lose in the scroll.
I use membrane blue, not it's
more expensive. James, I looked at your markings that you make in your donor. Why do you make such huge marks? When we know that the ink is toxic to the endothelium, you can very easily DSEC graph, or you think that because there is so much of stroma, it will not go to the endothelium? At least we know that the ink is toxic to the endothelium. Maybe for DMEC, yeah, DSEC, I'm not very sure what kind of cell loss it induces, but you could, I know you like things big. Yeah, sometimes I have seen, like, at least for me, the marking pens that I use, it usually by day 4, day 5, it fades away. But I've seen some DMEC done elsewhere. Even a year later, I've seen the mark. So I called up the surgeon and asked, did he use a permanent marker? But permanent marker doesn't mark the DM. I looked at it in the wet lab. I took a permanent marker, put it on a Sinski. By the time you mark your Sinski and you try to put on the DM, it's already dried up there, so it can't even, it doesn't leave an impression on the DM.
Intracameral restaining.
Yeah, intracameral restaining, again, like I said, that because you have a scroll that's going like this, if you want to stain, you can actually just put the dye, you can get the tissue to go into a scroll and then just put a little bit of dye in between the scroll and just wait. And that itself is sufficient. There are surgeons I know who say, why do you need, if you put a S or F stamp, you don't even need to stain the tissue because you can still see that. So I think there was one paper where they've done, when they punch out, they mark the edge of the graft. So they are putting ink on the trephine and they mark it. So you get a donor which has a purple mark at the edge and then just the F or the S stamp, and there is no stamp on the thing. And they are doing surgery, and you can visualize the graft pretty well, I believe.
I meant stain with vision blue, but stain a long time.
Yeah, then it fades away. Then again, to restain it, You can even stain with a quick stain in the anterior chamber, but remember that because you have removed the decimates, if you keep it too long, your cornea will get stained. So then you will have more difficulty visualizing it. So at a time when you have faced where you have done too much of manipulation and the fading away, then you can give a quick 10-second flush the chamber and then wash it out. You will still be able to stain the DM and get away. Otherwise, you can even, if your scroll is going into a tight scroll, then you can just inject the dye within the scroll. That also gives, because the stromal side is inside the scroll, not on the outside.
One question. Do you ever see that there is some kind of special trefines, or I mean, when you punch the 8mm, now when we get
that's the Zamalis technique you are talking about.
Maybe, yeah.
It's like the yogurt technique. So what it does is, just like when you want to peel off a can or a can of yogurt, you have a small edge which you can hold and then you can peel off the cap. So in DMEC, instead of the circular punch cutting all around, it cuts 90%, leaving a 10% small ledge.
Ledge, like extra ledge, so you can hold the tissue and get it outside.
You can initially peel that, hold that, and then the rest of the DM can be peeled. So that way, most of the central 8mm you have not touched it. You only touch that small peripheral limb that's been left out.
It could be also beneficial when you like whenever you are inserting in the eye, you see the ledge.
If you're using a pull-through, you can actually hold that ledge and pull through. That's also been described.
And get it outside.
But I was sent a few of them from the company, and we tried doing it. The problem is that if you don't free the edge, even if you create a ledge when you're peeling, the moment it comes to an area of resistance, you get a radial tear. We make a lot of pancakes or dosas in India, you know, and if I had not been an ophthalmologist, I would have been a chef. So when you make that pancake, if you try to flip, if you don't free the edge and you just try to flip, you end up breaking it. So it's pretty much the same. So that technique is good. It works in most of the cases, but cases where you have abnormal adhesions in the periphery, you can end up with and that's an 8mm you're doing with, not like a 9.5 or 10, where you still have, the tears occur in the periphery, the central part is still unaffected. But if you straight away punch 8 and then you try to do that and you get a radial tear, it's difficult to recover from that. Yeah, that's all before PDEC was developed. So a lot of, all these people, even Frank Price, Massimo Busin, they did S, where they had stroma on one side. Because one paper, if you see, Frank Price did, he put the tissue on the artificial chamber and he created a big bubble. Okay? So that was like a PDEC, so that was not decimates. He did that, then he punched out, but then he left a rim of stroma all around. And when he put that inside the eye, because of the rim of stroma in the periphery, the central DM often started getting detached because there was a ledge in the periphery that prevented the central part from attaching. So Massimo Busin said, okay, let's do the same thing, but instead of punching with a circular stroma, he punched little eccentric. So you got stroma on one side, and the other side was DM with a Duas layer. Nobody knew, but everybody referred to it as DM at that point of time. So the rim of stroma that you leave behind like a crescent was what you could hold with a microforceps and pull it into the eye. And because it was not like a circular rim of stroma, the chances of the central part getting detached was lower. So that's the thought process, that's how we evolve. I think there is nothing wrong in building up on what one surgeon has done and you trying it out. I think that's where only we can progress. You cannot have all brilliant ideas just coming out at one. We always observe something and then we try to improve, improvise, and we add our experience to it. And every meeting you come, you always pick up few points that you can go back and you can use in your clinical practice. That happens even after several years, whatever you do. We can conclude, yes. Otherwise, we'll keep going on.
Thank you so much for a great session. A lot of discussion, a lot of pearls, and thank you. We keep you too long today. Thank you so much.